we want to follow up with the notes that we were referring to. So what we want to do is do an analysis of the SOAP note. So last time we went over the basics of the SOAP note and how to make it really simple, quick, and highly efficient and effective with great detail. So that's what we covered how to do. So let's do an analysis and compare and contrast. This is an example of a SOAP note of one of the clients. And the reason we kind of pointed this out with a client is he was having a lot of difficulty with the type of his notes. He wasn't seeing very many patients. He was below average, which was not good for him because he definitely has the potential to be above average. But the main thing that we identified real quick is that he said he had to spend extra time outside of his office. And he's seeing below average patients, but he's got to spend extra time outside of his office doing his notes, especially his SOAP notes. And so I said, well, that's a system failure is what that is. Now, if you're seeing, 400 visits a week, then that's a little bit of a different problem, but not when you're way below average. You're under 50% below average, and you're spending extra time doing notes. No, that's a huge system failure. And like I said, you'll push away business. You're not going to want to take on more business to do more notes so you can stay after work longer and on weekends. That just won't happen. That's kind of a common sense thing. Okay, so let's go ahead and do an evaluation here of the SOAP note. And so here we go. We got the subjective part here, so you can see what he did here. He's got the daily encounter. And let's just do some critiques and what looks good, what could be modified or changed relative to this, okay? All right, so he's got the subjective part here. And let's go ahead. And you see here he's got the subjective patient assessment complaint. So he's got the complaints itemized out, which is good. Complaint 2, complaint 3, complaint 4, complaint 5, complaint 6. So it looks like there were 6 complaints, which is good. So you do have to do them individually with each complaint. Remember that. So now remember the subjective portion, the major component that we need in there, we talked about, is the quantification. Is on a scale of 1 to 10, we want the quantification from the patient's perspective, quantification. And we said, remember, when we use a scale of from 0 to 10, it gives us 11 variables. And remember, the more variables, the greater the likelihood to establish the need for care and show change. And so, all right, so here's what he's got. It says, Eric states his complaint has been better after treatment since the last visit. He reports his ability to participate with employment, homemaking, sleeping, social life. Has remained guarded with this complaint while concentrating, going to sleep, performing household chores, staying asleep, and using a computer. Today, Eric states rates his pain level at 7 to 10 using the visual analog scale. Okay, so that's what he says. So how would that be modified, changed, or cleaned up? So let's read it. Let's go through a couple of them, and then let's go how this would be cleaned up. So number 2 says cervical, left cervical dorsal, right cervical dorsal, sharp stabbing, tingling, and aching discomfort. Eric says subjective patient assessment. Eric states this complaint has been better after treatment since the last visit. He reports his ability to participate with homemaking, lifting, sleeping, social life, traveling, and or driving. Has remained guarded with this complaint while concentrating, driving car, getting in out of car, getting to sleep, performing household chores, looking over his shoulder, staying asleep, and using computer. Today, Eric has rated his pain 8 out of 10 on the visual analog scale. Okay, so let's go right into this into what are the problems with this and how could this be cleaned up. Well, what he's doing right, obviously, is he's itemized them out, good. And then he's quantified them on a scale of 1 to 10, good. But this is where he's wasting a lot of time. He's wasting a ton of time, and this doesn't need to be here. As a matter of fact, it's in the wrong place. He's putting in all of these ADLs. Now remember, we're in the subjective component. the subjective component of a daily SOAP note. And remember, what are SOAP notes? SOAP notes are micro trends. Re-examinations are macro trends. You do not make major assessments based on micro trends. They vary. They'll vary day to day. It's the macro trends that you pay attention to and that are much more weighted. Okay? So what he's wasting a lot of time on is this when he talks about all these ADLs. Eric stated his complaint has been better since last treatment. He reports his ability to participate with employment, homemaking, sleeping, social life has remained guarded with this complaint while concentrating getting. Okay, so here's the first thing. He's talking about ADLs and the subject component of a SOAP note. That's not where it goes, number one. Number two, the ADLs are called functional capacity indexes, and they're done at the re-exams. It's a very specific category. It's called functional capacity indexes. That's what they're called. Whether it's the neck disability index, the Oswestry scale, the low back pain index, okay? Those are called functional capacity indexes. And they're done, they are performed, and this is usual, standard, and customary. They are macro trends. They're not micro trends. Okay? So it shouldn't even be here. So he's totally wasting time putting that in there, and it's in the wrong place. So it shouldn't even be here. Number two, when he does have it, there's no quantification. Remember, everything about documentation is quantifying. So he's got things in here. He reports his ability to participate with employment, homemaking, sleeping, social life has remained guarded with this complaint while concentrating, getting to sleep, performing household chores. You get my point? So there's no quantification, and he's got a ton of subjects garbled together. Those are all separate individual topics that are quantified when you do functional capacity indexes. They're not bulked together, and they're not stated in a general form. So that is a huge waste of time and energy and misplacement. So what should have happened is that shouldn't even be in there, number one. We're only talking about the subjective component. And what it should have done is it should be moved into the functional capacity indexes at the re-exam and quantified. That's what should be done, not generic, thrown in together with everything else. So this is a huge waste of time, component and category, misplaced, and when he does do it, it's not even done well. Okay, so that's one way we would clean that up. And again, what's the good thing that he's doing? He's got a couple good things going on here. He's got a rated scale of 1 to 10, and he's got the individual complaint rated. So that's good. Okay, so this is some of the real obvious reasons that this is taking way longer. And here's the other thing too. Remember, with notes, you cannot use generic generated words. You know how there was some software they put out there, and there still is now, that has their own words in there, and then you click a phrase or you click something and it'll include its own phrase. Remember, you cannot do that unless you do one thing. Unless you go in there and paraphrase or you change it. You cannot use generated words from a software program to put into your notes on a patient. Let me be real clear on that. You never want to get caught. And some of the attorneys are pretty good because they know that chiropractors use a lot of generated notes. And I've had that happen in depositions where they'll just come out and say, "Doctor," and it'll sound like this, "Doctor, did you write those notes?" And the reason they're trying to get to that is they're trying to show, see, you signed off on this. Remember, when you're in a deposition or trial, you signed off on it. And you said that they were your words. Unless you said otherwise, unless you put in there, in other words, you use generated software notes and you put in there that these were generated software words, and of course that would be stupid to do that. So if you're going to do something like that, first of all, don't do that. But if you're going to use these they're called macros or phrases. You create your own phrases. Or take the phrase that they have and modify them. So when you're asked, are those your words? You can say, yes, those were my words. I created them. Okay? So be very careful of that, because it's very easy to destroy your credibility. And the example I gave one time is the doctor had in his notes, he had all the origin and insertion muscles. Where he had, like in the shoulder, he listed all the shoulder muscles. First of all, what real doctor in the real world would know every shoulder muscle and know the origin and insertion of every shoulder muscle? Okay? Well, that's what he had in his notes. And as soon as I saw that, now I was hired as the expert witness in that case. As soon as I saw that, I knew he was using software generated notes. And it'd be so easy for me to disqualify him, to show how his untrustworthy he is, by me just going, where's this muscle at? Where's the origin? Where's the insertion? Where's this muscle at? Where's the origin? I'd have just went right through his notes, and I'd have just buried him. And of course, once that happens, your credibility's shot. So never ever use words you did not create and then sign off on them. So anyway, having said that, back to what we're dealing with here. These are the core things that we have there. Those were the core key components for that. Let's move past, and they apply to everything. You can see that he's done it on every category. So we got 6 complaints, and he's done it on 6 categories. So guess how much time he's wasting already. This is not a 12-second SOAP note. We do SOAP notes in 7 to 12 seconds, and they're way more specific and quantified than what we have here. So this is the objective findings. So remember, you need 2 E&M components in the objective component. The objective component is really the only thought process of a SOAP note. So here we go. This is what he used. So he says daily objective findings. So he says spinal restriction subluxation, C2, C3. It says comma, C3, comma, C5, comma, C6, C7, comma, T1, comma. Okay, now there's a reason I'm pointing that out. Now the next one, it says extra spinal restrictions, subluxations, left hand, right knee, left T1 rib. Okay, so you get the point. Next one says pain tenderness, mid to lower cervical thoracic. Okay, we got that. Postural analysis. Okay, muscle spasms, range of motion, concern. All right, let's go and break that down now and go, how can we clean that up and make that better? Okay, first of all, remember we only need 2 out of 3 we only need 2 E&M components, okay? But you do have to have 2. And remember what I say, it's best to always use the E&M components that give the highest sensitivity and the highest probability. It would do no good for you to be doing, putting in there, say, as an example, cranial nerves and dermatomes, or let's say reflexes and cranial nerves. Those are not sensitive tests. And you would have just a lot of normal findings forever, and you would not be able to establish the need for care. That's kind of an example. So that's why I say, as a bare minimum, the tests that give the highest probability and sensitivity for the chiropractic patient, I'm talking about the typical neuromusculoskeletal chiropractic patient, is palpation that has 3 components. Number 1, it's going to check joint fixation. So we're checking one of the ranges of motion. We're checking overpressure. Okay. Number 2, point tenderness. We're going to check for tenderness. And then number 3 is muscle guarding spasm tension. Okay. So we got 3 E&M categories, and all of them have high probability and sensitivity with the standard chiropractic patient. In other words, you'll have some documentation to establish the need for care and get paid. Okay, so having said that, so he says spinal restrictions. Now here's the first mistake. He says dash subluxation. Remember, one of the main reasons attorneys do not work with chiropractors, there's two main reasons. The number one reason the vast majority of attorneys do not work with chiropractors is they don't know the benefit of chiropractic. It's not branded. It's confused with this thing called subluxation. But the second thing is the attorneys that do know a little more, they're afraid to put you in the stand when you're talking about subluxations and paradigm shifts. They're afraid to put you on the stand. And so those are the two main reasons that attorneys will not use chiropractors. Now, having said that, that's what the marketing has to overcome. But having said that, you definitely do not want to fit into that category. So let's go into, I would never, and remember, there's a difference between a medical subluxation and a chiropractic subluxation. So can you explain a subluxation medically? Well, we don't see subluxations. A subluxation is a minor dislocation. We don't see those in chiropractic for the most part. And I'm sure what he's referencing is the chiropractic subluxation. Well, that's when you're going to get in trouble. Because remember, if I'm any kind of an attorney, how stupid can I make you sound going into the world of subluxations and how you help and treat the immune system, cancer, asthma, allergy, bedwetting. I'm going to go into everything possible because it just shows the jury that, again, when you try to be everything, you're nothing. And that's the number one biggest problem with chiropractic, period. So the first thing I'm saying to you is leave out subluxation. That's the first thing I'm going to recommend to you. You're just going to put yourself in a world of hurt. So he does have spinal restrictions. Now, I'm going to identify which motion I'm talking about. So remember, there's three ranges of motion: active range of motion, passive range of motion with overpressure, and paraphysiological joint space or joint motion. So identify specifically, remember, personal injury, and it's not just personal injury. You should be specific with your data, with quantifying your data. You should be as specific as possible when, in any healthcare payment system. So I would, instead of saying spinal restrictions, I would have specifically said overpressure, range of motion. Okay, number two. Now, he put C2, C3, C4, Well, he put them down individually, not as motor units. Well, they move as motor units. C2 moves on C3, C3 on C4. So when you're going to put these fixations down, put down the joint motion. Well, C2 does not move on its own. It moves on C1 or C2. Okay? Now, you could say it's a minor thing, but I'm just telling you that, every now and then you're going to come across a good attorney. And so these would have been listed as motor units, because that's where the motion is. The motion is between two vertebrae. It's not a vertebra. If a vertebra is moving, it's cracked. It's fractured. Okay, so having said that, the other thing that I'd be very careful. Now, if it's true, I would do it, but because the way he has this listed, it's almost not believable because he listed everything. He put C2, C3, C4, C5, C6, C7, T1, T2, T8, T9, T9. In other words, it's almost unbelievable. So now, if that's the case, put it down, but I'm just saying, I've treated thousands of people. And usually fixations occur in a few segments. They don't occur, through the whole cervical spine. So you kind of lose credibility when you just make a blanket statement like this. So just be aware of that. And then what else should we have? So how should we have said that, the spinal restrictions? Well, typically in the neck, it'd be like C3, C4, C4, C5. That's where the restrictions typically are. And so it would have been, remember, when you itemize it, you want to do a couple things. You want to say the anatomy. So I do want to say I want to say the region, cervical. What specifically am I talking about? C3, C4, or C4, C5. Okay, those are the units. Whatever units are then I'm also going to include restricted or fixated, and I'm going to include overpressure. Okay, so the region, cervical, C4, C5, restricted overpressure, and then which anatomical motion, left, right, typically depending on how you palpate. Typically, palpation in the neck is usually left or right, just kind of lateral tilting for fixations. In the low back, it's usually posterior to anterior when they're prone. So I'm going to say the anatomical motion. So in this particular case, how would I have said this instead of what he said here? It would have said spinal restrictions or fixations. Either one of those words are good. In overpressure, cervical spine, identify the region, then the specific anatomy, C4, C5, and C5, C6. See, that's how it would have sounded because that's what's moving. The individual bone's not moving or it's crushed. And then I would have said left lateral flexion, if it was left lateral flexion where the fixation was. That's how that would have sounded. Cervical region. So it would have said cervical overpressure, fixation in the cervical region, C4, C5, C5, C6, left lateral flexion. That's how that motion would have been described. Very specific and quantified. Now, when you quantify, let me go into the quantify now. Remember, you want to try to quantify as much as possible. You want to always try to use the normal standards, but I said in many cases, or in some cases, you're going to want to use the functional capacity index because remember, it helps to give you variables. Because remember, if it's just a positive or negative, that's two variables as opposed to 0, 1, 2, or 3. Well, I got 4. So I have more of a likelihood, and it's way more descriptive than, say, positive or negative. So I want to use the functional capacity. Now, in the overpressure, in gross range of motion, you're going to do degrees. That's standard. You should go whatever degrees forward, back, left, or right, and they could only do this. Okay, so that's the quantification in active range of motion. The quantification in overpressure, use the functional capacity scale. It's too small of a motion to manually measure. It's too small. You would never be able to reproduce it. So you measure the quantification using the functional capacity scale. So in other words, when we do it, when I checked fixation, was it a 0, 1, 2, or 3? Well, if they had it, we know it's a 1, 2, or 3. Now it's going to tell me the degree. Well, if I could not even do the maneuver, it stopped me from doing it, it's a 3. 2, I could do the maneuver, but I couldn't do it fully. And that's a lot of what fixations are. You can do the maneuver, but you can't do it all because you go into the pain until they're way down in care, 2, 3, 4 months down the road. And then, of course, 1 is overpressure when you can do it, but there's fixation, and then there's pain or discomfort. Okay, so that'd be 1. So get used to always checking for fixations and identify it as joint overpressure. Identify the region, cervical, lumbar, thoracic, joint overpressure. Identify the specific anatomy, C4, C5, motor unit, and then identify which anatomical motion, left, right, and then identify and then quantify it. This would have been grade functional capacity grade 2. So if I was doing a voice dictation with that, I would have just said cervical spine overpressure fixation C4 C5 on the left grade 2. That's what that would have sounded like, and that's how fast it would have happened, with unbelievable high specificity and detail and quantification. All right. So moving past that, he goes into the extra spinal restriction. So same thing with extra spinal. He included his. Good. Pain and tenderness. That's the other thing. That's the other one you want to grade. So he put mid to lower cervical, cervical thoracic, upper cervical, cervical thoracic, lower lumbar, lower. Okay. Again. Okay. So point tenderness. I'm just going to say the anatomy. What anatomy? Like in this, typically when you do palpation and I do fixation on the left, it's typically going to be point tenderness, cervical spine on the left, C5, C6 on the left, See, because usually those go hand in hand, fixations with tenderness, because of the repair phase of healing characteristics. Okay, so that's how I would have identified the pain. Now let me go into the muscle next, because those are the common ones. So now you do the muscle, and I'm going to do the same thing. I want to identify. So what are the common muscle factors? Well, muscle spasm gives the greatest reimbursement, if you don't know that. Muscle spasms. Overguarding or muscle hypertonicity. Okay? So, but those are some of the descriptive variables with muscle, right? Muscle guarding, muscle spasms, hypertonicity, all right? So that's why a lot of times I'll just include muscle spasms. It's more descriptive medically and relative. So here we go. With muscle, I'm going to do the same thing. I'm going to say the anatomical region. Now, with the muscle, it's not a segmental motion like C4, C5. It's a region. It's cervical, lumbar, thoracic, elbow, wrist, whatever. Okay. So I'm going to say the region, and then I'm going to identify the muscle spasms. So in this case, it would be muscle spasms, cervical region, and if you say cervical, you're fine. You can add to it C1 to C7, all right? But cervical in itself is descriptive enough. And then add the anatomical range, and and that's when you're going to use either flexors, extensors, or rotators. Don't get specific. Use one of the anatomical ranges of motion when you talk about muscle. Flexors, extensors, rotators. So here it might be cervical, bilateral cervical muscle spasms with the cervical extensors. That's how I would have said muscle, the region, and then which motion, and then the description of anatomy, muscle spasms. So I included all of those right there. Okay, so those are the three common ones. Now he included ROM concern. He says, it says ROM concern. Now, first of all, what does concern mean? It means nothing. Remember, if I had 10 chiropractors and I said, what does ROM concern mean? I won't get the same answer with any of them. So you have to use what is standard and consistent. So, range of motion. Now, I'm going to assume that's active. Now, that should say active. If you're doing active, remember, be descriptive with which range of motion you're talking about. Is it active range of motion, passive joint range of motion, or with overpressure, or is it paraphysiological joint motion? Be specific when you're talking about which range of motion you're doing, okay? Because remember, you got a lot of good variables there. You got active range of motion variables, you got overpressure variables, and you got joint motion. You got a lot of biomarkers, meaning, establishing the need for care, need for treatment, and getting paid, okay? A lot of biomarkers just in range of motion. So it says entire lumbar and cervical spine and thoracic extension. Right knee and left hand was recorded as severely reduced with pain noted. Okay. So the only thing I would clean up there is, again, identify which motion you're talking about. And then he says, so he's doing the entire lumbar and cervical spine. I'm gonna keep them separate. I'm not gonna cluster the regions. So I'm gonna do active range of motion lumbar spine, active range of motion cervical spine, I'm gonna keep them. I'm not gonna cluster them like that. This is when it gets general. And remember, the more general you are, the more vague, diluted, the more worthless it becomes. So it says entire lumbar spine, cervical spine. So he clustered them all together. And then he did not even include which concern it is. Well, what concern do you have? Is it, or wait a minute, it says he did put extension. So he put entire lumbar and cervical spine and thoracic extension. Range of motion. Man, I tell you what, if I'm doing his deposition, I'm going, doctor, how did you measure that? How did you evaluate that, doctor? You see, that's just being generic. That is just being generic and clustering stuff in there. Then it says right knee, left hand was recorded as severely reduced. Okay. So, I don't recommend checking active range of motion, by the way, in day to day. That's a macro trend. That's not a micro trend. That's at re-exams. But if you wanted to do it, but then do it right. Measure it right. So he included that, and then the next one, he included a postural analysis. Remember, I said some of you guys do different things. So learn how to state them more specifically and quantifying them more specifically. So here he's got postural analysis, head forward flex, thoracic hyperkyphosis, and high left hip. Head forward flexed, thoracic hyperkyphosis, and high left hip. Okay, so I don't think I would change much of that at all. So he does have another E&M component, but how sensitive is that going to be? It's not going to be a highly sensitive E&M component in the beginning, more so, but it's not what we would call, because remember, we look at two factors always: relativeness and sensitive. Relative and sensitive. Well, posture is going to be a little more relative in the beginning, and it's darn well not sensitive. So anyway, it's additional. Would I hang my hat on it? No, but it's supportive and additional. Okay, enough of that. So that is how I would have cleaned up the objective portion, and then you go into the assessment portion, and this stays the same. Now Eric is guarded health and has made fair progress and recover with multiple residuals. Well, what does that mean, multiple residuals? So he doesn't say. There's a lot of generic stuff that, number one, it's generic. Number two, it doesn't even need to be said. He's just wasting his time. Because the assessment, remember, the portion of the assessment is the diagnosis. And the diagnosis essentially should not change for the standard chiropractic patient in microtrends from one visit to another. They change in the macro trends, in the re-exams, when you're evaluating all the bowel markers, not 2 or 3 of them. Unless something happened. Was there a magnifying factor? Was there a re-injury or something? And then I told you a lot of times in that case, I'll just change the adjective of a diagnosis from maybe mild to moderate, or moderate to severe. But essentially, the diagnosis is essentially, it says they remain the same. There's no reason to be changing your diagnosis and basing it on microtrends, day-to-day microtrends. So it says he has complicating factors, which include severity of initial episode of injury and nature of employment and positive x-ray findings. And see, you get into another problem here. So this is one sentence, and look how many different topics are in one sentence. It's complicating factors which include severity of initial episode of injury. So that's one topic. And nature of employment. That's a separate topic. And positive x-ray findings. That's a totally different topic. He's got 3 separate topics in one sentence, and none of them are quantified. And they shouldn't even be there in the first place. Okay? So this is like kind of almost when I see when I see stuff like this, I go, where did you learn how to do this? And that's typically when the chiropractor says, well, I got the template from my friend. Is kind of how that works. So the only thing that should have been really in there is the initial diagnosis remains the same, to be evaluated, and then I would just put on there to be reevaluated, and I'll just put the exam date. When's the next exam date? That's when you're going to reevaluate all the biomarkers and look at macro trends. So he's got the diagnosis under there. Okay, so he's listed all the diagnoses. You don't need to do that because they've already been listed. And then the treatment plan. Treatment plan is the same thing. So he's got primary treatment, diversified chiropractic, manipulative therapy to the C2, C3, C4, C5 levels, complaint 2. So he's listed the different complaints and then the treatments. And the treatments in the plan, they also should not be changing in microtrends. When you're seeing somebody once a week, twice a week, 3 times a week, again, unless something happened. It's the re-exams that you evaluate all the biomarkers and reassess not just the diagnoses, but then you reassess your treatment plans. And so this is also what should have happened here, is the treatment plan remains the same. Now, in the beginning, in the very initial diagnosis, when you came up with the diagnosis, that's when you should have just included the treatment plan. Well, what's the treatment plan? What's the goal of the treatment plan? That's when you're looking at decreasing pain, tenderness, range of motion, restrictions, increasing range of motion. And then what are you going to do it? What are the therapies are you going to do it? So that's what the treatment plan is. That's what happens in the very beginning. After you have the biomarkers, you have the diagnosis, you just spit out the treatment plan. So the goal in the treatment plan would be and I'm just going to go through each diagnosis individually, and I'm going to say, these were the biomarkers, this is the therapeutic protocol because of those biomarkers were positive, and our goal, and what our goal is. Are you trying to reduce it 50%, increase it 50%, 20%, in what kind of time frame? That's how. And so that becomes your treatment plan until the next re-exam. And so that's how that is set up. It's already should have been done once and only once, and not every time at every SOAP note. So when you get to the treatment plan here, it should be treatment if there's no change. And remember, over 80% of the people, it doesn't change. Treatment plan and goals remains the same to be reevaluated at the next re-exam. Done. Because I already had the diagnosis, I already had the treatment plan. Oh, that's already there. I don't have to re-say it 20 times. And it's way more specific than this. Primary treatment, okay? So this is how you can clean up your notes. This is kind of a classic. By the way, what we're seeing here it's not picking on him. This is just classic. It's kind of real common. A lot of these mistakes that we're seeing in here are very common mistakes that chiropractors do. And again, a lot of times it's because you go to a seminar, and you'll go to a SOAP note seminar, and it'll be somebody talking about the Medicare guidelines, and they'll be referencing the medical patient, not the chiropractic patient. The chiropractic patient is not the medical patient. That's why you don't change the diagnosis on every visit. Well, in a general practitioner's office, when people only come in once or twice for a particular problem, and then when you see them again, it's a different problem. Well, yeah, you're going to have a different assessment almost on every time they come in, because that's the protocol of a medical doctor's office. That is not the protocol of a chiropractor's office. We'll find out what the problem is, the diagnosis. We'll come up with the treatment plan. They'll go through a series of treatments to help those biomarkers relative to that phase of healing. We determine which therapeutic protocol used based on the biomarkers relative to the 3 phases of healing. And we know all that based at the re-exam. That's when we look at the subjective, the hybrid, and the totally objective. Are they getting better? Keep progressing. Are they getting worse, or are they staying the same? They're getting better. I'm going to just continue forward. Or do I need to modify now because I'm moving into another phase of the 3 phases of healing? Maybe now going more away from pain and tenderness, maybe into now active range of motion or passive range of motion. Are we going from... so that's an example of how it would transition. All right, so I just wanted to just do a kind of a comparison, contrast. These are very common problems, but you can see why this is taking. And he did put these on what are called mic. So he did create these statements, but he still has to go in there and post them and do multiple times and hit all that. And this is a major reason why he's got no time to see patients. So he's spending time outside of his office writing notes and SOAP notes, and he's under 50% in productivity. And that's why I say you have a systems problem. And so when you look at offices, and I'll just tell you right now, when I evaluate offices for growth, these are the 7 factors I'll look at. These are overwhelmingly the 7 issues, one of the 7 issues that it's going to be. Number 1, do you have a space, labor? Number 1, 2, and 3. Do you have a space issue? Well, it's rare. Chiropractors usually have too much space. Also, they typically have bad design flows. So space. Next, labor. Sometimes most chiropractors have too much labor. But every now and then you see a chiropractor that doesn't want to hire people. But that's much less. Most chiropractors overhire for the volume they're seeing. So, space, labor. Next is equipment. Well, do you have the right equipment for your therapeutic protocol in each phase of healing? Most chiropractors don't. And the biggest category they miss out on is the active range of motion. And most chiropractors don't associate specific therapies for very specific biomarkers relative to specific phases of healing. They don't think of it like that. They just do what their buddy does. So, space, labor, equipment. Then you go into knowledge. Does the chiropractor know? Well, we got a knowledge problem here. This is a lot of stuff that doesn't need to be done. The things that could be done way better. We definitely have a knowledge problem. Then we have a skill problem. Do you have the ability to do it? Because remember, there's a big difference knowing about something versus having the ability to do it. And the most common problem with chiropractors in growth is the number 1 and 2 problem is knowledge and skill. It's not space, labor, or equipment. It's knowledge. They don't know what they don't know. So that's space, labor, equipment, knowledge, skill. The next one is motivation. A lot of times when doctors start making a little bit of money and they get out of survival, remember the highest natural motivator is survival and security. Well, as soon as they start making some money, that's typically around, say 80 to 120 visits, they start making $100,000 a year, motivation goes to hell. Natural motivation goes to hell. And it gets to be a big problem. Most doctors don't recognize it. They don't know how to act on it. And so it's a very limiting growth factor. And after motivation is management. Management is a problem that I see after doctors maximize their personality. So they're pretty good at taking themselves up to 150, 200 visits a week, but they can't go past it because it's a personality-based business. It's just them pushing, and they don't have good systems, and they don't have good leverage and good management. And so the next one becomes a management issue. And those are the 7 factors that I always evaluate, and overwhelmingly it's one of those issues. So real quickly, I look at this. He's seeing below average, below 50. He wants more new patients, but he's got huge negative. He's staying after work to doing notes. I go, let me see your soap notes. I didn't even look at his initial exam notes or re-exam notes or medical reports or narrative. I haven't even looked at that. But this is just a huge indication of what everything else is looking to look like. And I go, well, you're not going to see any new patients because you're not going to want more negativity in your life. That's just kind of common sense. And so we have a systems problem. So we have a knowledge skill problem and a systems problem. We don't have a new patient problem. We don't have space, labor, equipment. We've got a system. We don't have a vacuum. Remember, if you don't have a vacuum for growth in those categories, space, labor, equipment, then you will not grow. And it's just like Mother Nature will not pour more water into a glass that's already full. You'll resist in all kinds of ways, subconsciously, all kinds of things. You'll run business off subconsciously. So, having said that, this is like a really classic example of soap notes and how they can be cleaned up and how they're just wasting a lot of time. Okay.